we've been trying to essentially alternate between interventional and open surgical guys from the beginning of this. And what you represent is the first edition of a truly dual trained, but somebody who's really the generation where that really has taken over our business. I don't see us live on Insta yet, Flo.
We are.
Okay, I believe you.
We have 101 people. Say hi.
Okay, hi. Hey guys. So Elad is my little big brother, I like to call him. When I finished my training in 1998, Elad was just beginning his, or just finishing medical school. And during that period is when it was kind of like after the asteroid hit the Earth and like all the dinosaurs got killed, and then what grew out of that was what, you know, the new Cro-Magnon man or something. And you know, I was sort of right in that period, and Elad from the beginning, I think, saw himself as a vascular neurosurgeon in a new way. Rafael and Yafell have pursued this alternative course of going into interventional neuroradiology through a non-neurosurgical route. So the beauty of catheter-based treatment actually is there are multiple pathways, and we'll talk about that. I think for this audience, things about your lifestyle, the training, the stress you're under will come up, and how you know, each of you guys dealt with that in your individual fields. What's great about this now, we have Yafell, who's a radiologist, Rafa, who's a neurologist, Jason Ellis, who joined us, who's an open surgical neurosurgeon, and then and Elad, Jason, and then Elad, who's I think really, you know, defining the future of interventional for neurosurgery, for that matter. Now, Elad graduated from Dartmouth, where he rode crew like me. He was much bigger and faster and better than me, and then went on to medical school at George Washington, correct?
Correct.
And then after med school, he really at one of the preeminent programs in the country was University of Pittsburgh. And I think that the reason why that place was so great is it's had some of the luminary people in multiple disciplines that Elad got exposed to. But his greatest decision, I think, and Elad's one of these guys that you don't get to become a chairman at Elad's age without making tactical decisions and really thinking about the next step. And I'll ask you to talk about a little bit, because I'm kind of the opposite of that. And his decision to go to Buffalo to join a guy named Nick Hopkins, L. Nelson Hopkins, I think was the best decision you ever made. And when you combine Elad's work ethic with Nick's leadership, he went to Buffalo for both fellowship and then was kept and stayed on faculty. And in addition to that, he has an MBA as well. He's thinking ahead to the next phase of his career. And he's always been one step ahead of the game. And, you know, my apocryphal story, which isn't really apocryphal, it's real, which changed my life, was being at a meeting with Elad in Jackson Hole, Wyoming, in the summer of 2009. And it's like one of these meetings where they show cases, and I comment on something, and it was, I think I recommended something open surgical. And he goes, "Langer, you can do whatever you want, but if you keep doing that, you're not going to have a job in 10 years. And I was like, fuck you. So, but he was right, actually. And about 4 months later that year, he was the one I called because I realized I had to get that extra training in catheter-based treatment. And they were, he and Nick and Adnan Siddiqui, who was his partner, welcomed me up there with open arms and really trained me how to do catheter-based treatment. You know, this changed my life. It led to a totally new pathway. It led to me going to North Shore, coming to Lenox, and really the experience of Lenox grew out of that decision for me, just like the success at Buffalo and your success grew out of your decision to join Nick. So that being said, I think you know, the first question is, you know, what were when you're in medical school or college back, you know, in the 80s, what were the things you were thinking about? And again, this is primarily because of the group we have. You know, how are you organizing yourself? You know, what were some of the things? I'm going to ask all you guys to do this. You know, I'll start off with Elad, and we can just have a general conversation. What was the things that, you know, what were the seminal moments? What were those epiphanies? What were the things that gave you pause that led to the good decisions that you made? And did you know how good of this you were making at the time, or was some of it just luck?
You know, I think my first epiphany would have been at U.S. junior camp. And, you say I'm bigger and faster, but at U.S. Junior Rowing Camp, I was slower and undersized. And I realized sort of everybody has a superpower. And I think if I had to say what are my two superpowers, it would be kind of being able to see around the corner, maybe 5, 10 years ahead, and also grit. And I remember it came down to the last 2 weeks of camp. The guys who get selected get to go represent the U.S. and Europe at Junior Worlds. And I end up winning a seat race, and I get called into the coach's office, and he says, the good news is you made the team. The bad news is all your gear has somebody else's name on it because no one thought you were going to make the team. So anyway, we went over there. But the point is, every night when I went to bed, I tried to visualize that I'm going to outwork everyone the next day. Everything I did that day was to be as fast as possible because I know I needed every ounce of energy to sort of make this team, and there was nothing more important. So I think that translated then into medical school that might not have been the smartest guy in the room, or maybe I didn't come, I didn't have the best sort of medical background because I was rowing in college for 4 years. But again, it was sort of every day, put the blinders on and outwork everybody. And that carried into residency. And then I was fortunate enough, as you said, to be at Pittsburgh, where I had mentors like Dr. Janetta, who was the father of microvascular decompression, and Dave Lunsford, who bought Gamma Knife or radiosurgery from the Karolinska to the U.S. So we had all these visionaries and luminaries. And when I went up to Buffalo, Dade and Peter said, you're going to learn a lot of endovascular in Buffalo, but from Nick, you're going to learn a lot more than endovascular. You're going to learn how to look at the future in a certain way. And I think that was a second epiphany, that I don't want to train you have thousands of students who have signed up for the virtual internship, and you have people on this call. I don't want to train the people the way I trained. I want to bring cutting edge technology. I want to look ahead, and I want to surround myself with people that are looking ahead. So when I was at Pittsburgh, I wanted to clip aneurysms and be a vascular neurosurgeon. But I said, in 5 years or 10 years, no one's going to send me their cases because I can't offer anything different than the guys who've been doing this, the dinosaurs who've been doing this for 20 years. So how can I separate myself? How can I distinguish myself? How can I create something special? And that was endovascular. And so maybe I didn't do it for the right reasons. I did it to sort of maybe create an edge, thinking I'd still clip aneurysms. But then once I learned about endovascular and how wonderful it is for patients and minimally invasive for the right anatomy, I think the rest sort of fell into place.
Guys, you have similar feelings about what you end up doing?
I mean, from my standpoint, I agree with Elad that it's critical for people to feel empowered and to feel like you have an edge, and whether it is competing in sports and working out longer hours, knowing that while other people are sleeping, you're really putting your time to get better, or whether it is in medical school, learning and reading so that you don't get surprised. That's a critical quality, I think, is special in order to be successful in whatever you do in life, whether it is a neurosurgeon, an engineer, banker, a baseball player, whatever you are. And the other critical piece that Elad mentions is the mentors. Some of that is by luck, ending up in a place where you have great role models to follow their lead, to listen to grow, not just intellectually, but also from within, to get to know how to become a leader. That's talking about Elad and David. You are both tremendous leaders. You're both regarded as individuals that people want to follow. And you do it by example. You do it by being, people that care, that want to do the best for their patients, want to be a great doctor, but also who wants to foster growth from the people that are following you, and giving opportunity for your partners to shine. These are incredible qualities that all of us need to get inspired by. You mentioned your mentors, and for me, it was really the first time I saw someone doing neurointervention was Robert Rosenwasser, and I said, "This is what I want to do." And I was doing neurology residency, and I felt that something was missing, or a lot was missing. And what was missing was that opportunity to be able to have a direct impact right away, save a life, cure an aneurysm, and this gave me the tools. And looking at him, I said, I need to figure out what I need to do to be like this guy. And then fortunately, I ended up having Alex Bernstein as my mentor, professor, and then I was his junior partner for several years. And I learned a tremendous amount of not just medicine or intervention, but of life experiences, and the good and the bad. You learn about everything from someone. And we have to mention it. It was by serendipity, ended up meeting Dave Langer in that environment. And then we become best friends and partners, which later on, Elad, I'm gonna ask you, how was David as a fellow? But we'll leave that for later.
We have good stories there.
Well, was there anything, I mean, obviously, you know, there are all these rowers who seem to think about rowing, but, you know, this is your family structure. I know your father, who's just an amazing guy. I was lucky enough to, I tell you, whenever I meet sons and dads who have those kinds, and I know Raf's dad too. You know, I lost my dad young, and but there are certain guys that I have relationships with, and I see them with their fathers. So it makes me miss my dad. You know, your father must have had a huge impact on you. But what was it him? Where do you think this kind of ambition came from? Or was there? I know your brothers are super successful. Guy Levy is successful. And you know, what are the things in your, you know, back in high school or seminal events in your life that, you know, brought you to this place where you are now?
You know, I think it comes a little bit from an immigrant culture. My father wasn't born in this country. I wasn't born in this country. And I was old enough to remember moving here to New Jersey, living in a small apartment, sleeping on a Walmart air mattress, those inflatable pool mattresses that you throw in your backyard for $10. And, you know, shopping, you know, clothes or hand-me-downs or thrift stores or whatever they could afford. And I think humble beginnings, being appreciative of, obviously I know during this time, this country is facing some serious issues, but I still think it's one of the best countries in the world. And fortunate that we were able to come here and become citizens. But I think those experiences, humble beginnings, and realizing the opportunities are here if you really dig in and just commit and work. The opportunities are endless, and I think that stayed with me, and I hope I've translated that to my two sons and my daughter. And I think, you know, same with my father. He grew up very humble in the Middle East, very humble beginnings, and went from being a soccer player to being an OBGYN with limited opportunity because he was an immigrant. But I think it's those experiences that early on in my life that has sort of shaped that grit and that focus.
How about you, Jay?
In terms of having an edge, I mean, I think I have an edge right now. You know, I've sort of started my career on a path that is not as well traveled anymore. You know, I'm doing open cerebrovascular, skull base, and it's really luck that I'm able to do that. I ended up here. I have Dr. Langer's support. I have Raf and Yafell. So that's my edge. You know, I have great guys in my corner. In terms of coming into neurosurgery, I think it's the same thing. I think, you know, people who go into neurosurgery really want it, and they'll do what they need to do to make sure they get into the career they want. and it's working hard. It's having sleepless nights. It's all that stuff that we all did. So that's the edge, you know, just having a goal and sticking to it and making sure you achieve what you want to achieve.
Yafell, you have any thoughts on that? With what you went through?
Yeah, you know, things happen sometimes in a weird way in life. And in my case, you know, right before applying for residency, when I was a student, I was, you know, I knew I wanted to do something related to the brain. I just didn't know whether it was going to be neurology, neurosurgery. And then right before application, I was advised to go and check out what Tim Nelson was doing at NYU. So that did it for me. I stayed there for a couple of days. I saw the cases. I was like, wow, I just want to do this. I want to stay here. I remember in those days, those cases were lasting, I don't know, one case would last 3-4 hours, 5 hours. And I was like, this is amazing that you can go with a catheter far in the brain and cure someone. So that kind of did it for me. And obviously I didn't go the neurosurgery route. I went the radiology route. But, you know, in the end, I'm working here for you and with you guys. And I think it's a great environment where to be, trying to assemble a team that, you know, has, you know, different backgrounds from different people.
You know, a lot. I think.
Jay, I want to tell Jay, this is your lucky day. So David survived the dinosaur mass extinction barely, but you're still very young and you're surrounded by super talented interventionalists, super talented.
Yeah, I know.
Let me ask you this question. Why would you not take advantage of the people that you have sitting there right with you at the tremendous center at Lenox Hill and learn this skill set? So one day, who knows where you may end up, you're going to be able to offer comprehensive vascular training to your patients.
Well, Lenox Hill Neurosurgery offers comprehensive care as a team. I don't need to do it all. I have a great team, and you know, we all have our strengths. And yeah, you know, Rafa's not doing the skull base approaches for pica aneurysms. He can coil some of them, but some of them he can't. So, you know, and some of them you don't need to do a huge skull base whack, and I send them to Rafa. So it's a give and take.
Actually, Jason has the job that I wish I had. Seriously, like if the environment that I was in as a young attending was the way it was here, I never would have come to Buffalo. It would, but and it might have been a mistake. But of what Jason's able to do, and is he's taking pieces from all of us, whether it's, you know, Gamma Knife, you know, the minimally invasive clot retrieval, open surgery, bypass, carotids, skull base, occasionally doing some spine. You know, because he likes open surgery. I think if you want to commit to full-time vascular, you're right. I don't think if that's all you want to do, you can't afford to not do interventional. The problem with that, though, and I think unfortunately with stroke, is that the lifestyle and the practice of interventional almost is prohibitive in some ways to develop to be as good of a vascular neurosurgeon for this youngest generation as it was even for you. Just because diffusion of volume, diffusion of the numbers, to get to the point where you're really not clipping and bypassing enough aneurysms to have that without being committed to it. It's hard for Jason, but because there's two of us and I, you know, for the most part, give up to Jason whatever I possibly can within reason. And, you know, just so I can just keep doing something, you know, but you know, the truth of the matter is we're very honest about it. And if you don't have that honesty and there isn't a give and take, then it fails. And that's why most places you can't get away with it because, you know, but I agree with you a lot. I think if you are going to do vascular neurosurgery, you have to do interventional. If you want to be a cranial neurosurgeon, skull base, you know, neurosurgeon that does aneurysms, you can still probably do that. It's just that may or may not survive as long as you have everything else. You're willing to give up aneurysms to do everything else versus I'm not willing to give up vascular. And if I'm not willing to give up vascular, then you got to do catheter-based treatment.
I think, Jason, you're very fortunate. As I said, not only are you surrounded by talented people, you're surrounded by quality. You have a quality team there of human beings. But for the students who may be on this call, if 5 years, whenever you graduate, and even graduate residency 10 years from now, if you want to have your maximal options, I don't even think it's even going to be separated. I think most fellowships in the next 3 to 5 years are going to be a dual kind of training fellowship, because truly that's what the market is going to be demanding. It's not even going to be really an option. They will have skull-based fellowships, of course, and I think that's still much needed for tumors that require those techniques. But if you're going to want to be a vascular neurosurgeon, dual training isn't going to be an option. It's almost going to be a requirement. And even the RRC now, the residency and the ABNS is going to be mandating all neurosurgery residents. And I'm not sure if it's true for neurology and radiology. I'd ask your colleagues on the call, but you're going to have to, the neurosurgery residents are going to have to scrub in for stroke intervention. That's going to become part of the basic neurosurgery training, because stroke is such an important, it's such a prominent part of vascular neurosurgery now, as it is for vascular neurology and neuroendovascular radiology.
And I know that David has spoken to you about this before, about that model of having every neurosurgery resident trained in basic catheter techniques, catheterization, doing a diagnostic cerebral angiogram, and being capable of performing mechanical thrombectomy for acute ischemic stroke. In the line of thought of similar to a subdural hematoma evacuation, that whichever neurosurgeon is on call that night for that service, that hospital, will take care of that issue for those patients. Do you foresee that that would be a goal for neurosurgery residencies throughout the country, training general neurosurgeons to do mechanical thrombectomies?
I do. And we're having those discussions now at the board level. So if you think back 15 years ago, and when David, when you were a resident, spine instrumentation was something that was rare. Most guys had to go out to do fellowship to learn how to do complex spine. So now, today, complex spine fellowships aren't how to put in pedicle screws. It's about deformity, robotic, MIS. It's kind of that next level. So if I use the spine model from 15 years ago, I think basic endovascular, most residents should hopefully be able to come out carotid stenting. Obviously, some strokes are very complex, some are, but hopefully stroke, some type of emergent procedures, they'll be comfortable doing, like most neurosurgeons today are comfortable doing ACDF, simple pedicle screws. Complex AVM, AV fistula, transvenous cases, spinal angio, things like that, that will still require fellowship. Just like, Jason said, for skull-based, there's still skull-based fellowships are needed, but most neurosurgeons can come out taking out basic cranie for tumor.
And in that same topic, what's your opinion on interventional cardiologists, vascular surgeons, interventional peripheral radiologists that are interested in doing mechanical thrombectomy procedures? And because the issue for the audience is that ischemic stroke is the busiest emergency that we have in neurointervention. And right now, if you dedicate your career to do neuroendovascular, you want to do, obviously, not just stroke, you want to do everything. You want to do not just emergencies in the middle of the night and weekends. You want to be able to treat a brain aneurysm, a brain AVM, a stenting, a spinal cord AVM, fistula, facial hypervascular tumors, and have a diverse practice, adults and pediatrics, that you can get all that type of volume from a hospital or referring emergency rooms. However, to be able to do 24/7 treatments for a stroke, you need more than one person, and you need to have 1, 2, 3, 4, 5 partners, depending on the volume that you have, and that dilutes the practice of neuroendovascular, because then you have less aneurysms, less tumors, less stents to do per person. And then one of the options is that instead of just having a neuroendovascular formally trained individuals doing the mechanical thrombectomies, could we have a supplement of interventional cardiology, peripheral IR, or vascular surgeons involved in the cold pool? What's your opinion of this?
Great question. Again, I think the market's going to bear that out. My preference would be just like in a group, if a guy comes in with caudate equina, you don't need your spine specialist to take out a lumbar disc that's causing caudate equina. My vision, my hope would be that we train enough neurosurgeons that in the group, if a stroke comes in, the general neurosurgeon will be able to catheterize and do a thrombectomy. Okay, aneurysm, AVM, no, that's fellowship. I'm not a fan of the cardiologists and the peripheral guys doing this. I think if they're willing to commit 6 months to sort of a fellowship, understanding the anatomy, the physiology, and the techniques, they're already skilled with wires. They already understand catheter manipulation, so they have that skill set. If they're willing to undergo some more training to translate the interventional skill set into the neuroanatomy and physiology, I'm okay with it. You make an excellent point. We need manpower, and we're hoping to grow that in manpower organically through neurosurgery, through resident training, or through interventional radiology, or through, obviously interventional, as more interventional neurologists become trained.
No, I think one of the problems I see, and I've talked to Rafa a lot about, in addition to the stroke center problem, is that the devices are getting better and better. That it's becoming easier and easier to do the difficult things. The biggest leap was, going from open surgery, not that interventional is easy, but if you put the training in and you have to show the grit, it gives the opportunity to more people that skill set. There are people who never did a neurosurgery residency who could now, treat very complicated giant aneurysms, whereas, a few years before, no one would touch those. Most neurosurgeons wouldn't touch those things. That my first epiphany was coming out of fellowship, and the first pipe I put in, this huge hypophyseal aneurysm, it took me like an hour, and the guy looked like a rose in the ICU. I'm like, I'm screwed. It used to take me 9 hours, a lot of this, and IMAX that, and then they'd be in the unit for a week, and they'd be, have to struggle with ischemic stuff and blah, blah, blah. So that was the big change. But now, what's happening is the technical difference, because the improvement in the devices and the ease of putting devices in, you're starting to degrade. It becomes a volume business. And that, to me, is the disadvantage when things get too easy. It makes them safer, but then you give the opportunity to more people to treat the same disease. It doesn't increase the numbers, but then the thresholds to treat get lowered. The indications change. People take more seeming risk. Where are you on that? Like, how do you, it's just that the market's going to define that.
Exactly right. You mentioned the flow diverter, right? What was Pipeline approved for? If you go back to the FDA approval for flow diversion, it was for inoperable aneurysms. And now every 4 millimeter sidewall aneurysm that probably doesn't need to be treated based on randomized prospective data is being flow diverted with a 20 or 30 minute procedure. I'm sure you see it in your community. We see it in our community. To your point, it's becoming, you don't need anesthesia sometimes. It's becoming a 30-minute procedure. So as you said, the indication to treat and the threshold to treat is sort of, the barrier is becoming much lower. And the market is going to decide who's treating this. If people are trained and they're safe and patients feel comfortable, they're going to get treated where they're going to get treated. In the end of the day, I think our community, you guys, this is why we've created the RFP. Are you familiar with the RFP, Request for Focused Practice? It's a multi-board, it's radiology, it's neurology, it's neurosurgery. We've established standards. You take a written exam after you're boarded, you submit cases, and then you get a certificate, a request for that you're officially recognized by your specialty board, neurology, radiology, or neurosurgery, as someone who is recognized as an expert in this endovascular practice. Hopefully that creates some differentiation, but you're right. I think now, David, even you can make this look easy.
Actually, this topic of who should be doing this has been ongoing for more than 20 years. This is nothing new, and we were talking to Bernstein a couple of weeks ago, and his answer to this was, "This is progress," and he's right. You cannot fight progress. Actually, we should applaud progress. And this is where we are, and we will continue to evolve, and we will have newer devices and easier to be done. Robots that will be doing it while you're at the beach, and that's reality. It will be happening. So,
I think there's a lot of metaphors with warfare, and I used to use that Indiana Jones movie where the guy comes out with a knife, and the guy Harrison Ford just picks up a gun and shoots the guy. I mean, this guy spent all this time learning how to manage a sword, and then now you have guns, and now that swords are useless. And it's really similar to that, like the samurai warriors of Japan, they had to convert to guns to defend the country. And even today, we're using drones on terrorists, same kind of thing, where we don't need to even be there, and you can, and that's why these are weapons in some ways. But I think that the onus is on our generation, really your generation. I'm beyond this at this point. This is going to change things. I think the point is we're using devices that probably we don't have good data on many of them. The web, I think, is a perfect example of that. I think it's one of the most ridiculous.
By the way, you haven't liked.
Saw your Twitter, didn't you? You tweeted that today, right?
Yeah.
Didn't you tweet a web kit? You did a nice one. It was nice.
Did what today?
I tweeted a web.
You did?
Tweeted.
Yeah.
He treated and tweeted a web kit at about the same time.
Well, at least he did one that we probably all agreed upon.
That was actually my case for clipping.
Oh, shit.
David, you're right. That's a great example of a technology that people are excited about. It's an for people on the call, they don't know. It's a mesh ball that you put in the sac of the aneurysm. It does require some finesse and some skill, which obviously Rafi has. But the long-term data is not out there yet, at least in this country, and some of the data is questionable. When these recur, how do you treat them? It becomes problematic. So I think our job as instructors and educators is now becoming who should we really treat, right? We have technology. We can treat almost anything with a relative low morbidity now, right? I think we need to train the next generation into really, would you treat this if this was your mother? The residents hear me say this all the time. Would you treat it if it was your mother? If the answer is no, we're not. If the answer is yes, then like you do there, you have a multidisciplinary conference, clip, coil, stent, nothing, bypass.
There's a question, Insta, is how we organize surgeons for the purpose of increasing efficiency of surgeries or respond to an increasing number of patients demanding treatment. That's interesting. It's a little bit, the syntax isn't quite right, but we've increased the number of people that can treat aneurysms because stroke's the demand. And how has that impacted the hemorrhagic disease? We're changing because we've trained so many more guys and women who can treat one problem. It's now, affecting our ability to treat, or it's changing the way we treat something else.
Look at I think that's a great question, whoever submitted that. And if you look at the cardiology model, I think we can see what's going to happen. So cardiologists began training many more because of heart attack, right? Myocardial infarction, STEMI. But in the end of the day, outside of these emergencies, what were they going to do electively? So you see a lot of cardiologists move into the periphery, right? They started treating legs, and then they moved up. And most carotids in this country right now are being stented by cardiologists. 80% of carotid stents are being done by cardiologists. And now there's some movement of cardiology, as I think Rafi alluded to, that they're going to want to move into stroke intervention. So if we train specifically neurointerventionalists because of the stroke demand, what are they going to do when they're not treating acute stroke? So there's probably going to be a decreased threshold on the elective
and lines into 4 millimeter sidewall aneurysms.
There you go.
So going back to the beginning of the hour, as an introduction for people that are listening, David trained in endovascular after he had been in practice for 11 years. So that's very unusual. Usually people, when go to medical school, residency, and then start working right after, or after residency do a fellowship or 2 fellowships and then start working. David was already working for 11 years and had become a world-renowned cerebral bypass neurosurgeon, arguably the most challenging, difficult procedure in neurosurgery. And then he decided to go ahead and train in neurointervention. And that is a decision that is rare for many reasons. He already had a lifestyle, he already had a practice, and he was living in Manhattan, and he decided to train in Buffalo. And that is very, requires a type of person that thinks very different, that is very humble, that is a person that is very curious, a person that is really looking for a challenge in his life that maybe he didn't even need that challenge, but he made the extra effort to be able to train. And so going back to the question, Elad, how was David as a fellow, and how was the experience for you training someone that was older than you, more senior to you in neurosurgery, but you're his boss? And how did that come about?
So, look, great question. Disclaimer, David and I are great friends, similar mentality rowers. So that's sort of the bias. Training him was a gift. It was really a gift because I was a young instructor at the time, and I probably made mistakes as an instructor by either giving too much leash or not enough. And he's just such an excellent human being that even though I was training him in endovascular, he was coaching me in life. But let me talk about grit. This is a guy, like you said, he was world renowned. He was doing the laser bypass. I think, where was it? In Amsterdam, and somewhere in Europe, Amsterdam. I flew out to outside of Amsterdam. He had a thriving practice in New York. And this guy would get on a plane, maybe it was Sunday, fly to Buffalo, go from being a full attending, an instructor, to being a fellow, taking orders from other residents and young instructors. And then Wednesday, take that hat off, go back to New York, and then run his practice. And did that for well over a year, basically splitting his time in 2 cities, splitting his practice, losing revenue, losing income, probably his practice. That is great, and that's sort of entrepreneurial, that you're putting everything into what he thinks is his startup, his next chapter in life, because he wanted to do this and believed in it. And for me, it was a gift because he allowed me to sort of cut my teeth as an instructor. And even when I maybe, who knows, my teaching style was off, he tolerated it. And then afterwards we'd go out for sushi at his favorite place, Cooney's. And, we'd sort of have a detox about it, or we'd talk about it. And I think I learned more from him about humanity and about the field and about the world than I was able to teach him about endovascular. But I missed that. I missed that year and a half with him. And I think the residents saw that at his age. How old were you at the time, David? 40 something?
I was 46.
At 46, he outworked every resident in the hospital. And I tell my residents this: never be outworked. You can't control much in life, but you can control how hard you work. Never let anyone outwork you. This guy outworked them all.
Ogilvy outworked me.
Yeah, one little story. So we had another guy who did the same thing, Chris Ogilvy. He was at Mass General at the time. He had a similar thriving practice in Boston. It was going to snow the next morning. So Chris said, I'm going to come in and round early. Chris wanted to write at 50 years old. At 50, he wanted to write all the notes in the ICU before a resident wrote one. So David, not to be outworked, said, I'm going to go into the ICU before Chris, and I'm going to write the notes before Chris. So David shows up to the shuttle from the hotel because they stayed at the Holiday Inn. So there's already probably half a foot or a foot of snow on the ground, and he's waiting for Ogilvy. It's 4:30 in the morning, and he finally tells the shuttle driver, take me to the hospital before it gets too much snow. And he's like, by the way, did you see the other guy? And he's like, oh yeah, the other guy left before there was any snow on the ground. He showed up at 3:30 because he didn't want Dave to write any notes. So eventually they came to an agreement that no one's going to show up before 3 in the morning, and they'll split the notes.
There was a foot of snow on the ground at 6 in the morning or 5 in the morning. It was like 5 in the morning. I'm going into fucking work. It was like a foot of snow on the ground. And I said, I didn't see Chris. And he goes, oh yeah, he went early. He goes, and there was no snow, and I took him in. I'm like, there's a foot of snow on the ground. What time did he go? 3 o'clock? Like, I was just dumping. It was like, oh my God. The guy goes in at 3 o'clock in the morning to go. I was like, that's it. I let him drop the mic. I was done. But I tell you what I learned about from that experience. No matter what you do, learning is a process. And, just because you were good at one thing doesn't automatically make you good at something else. And what I missed in the fellowship was doing it the way I did it 3 days a week. And you ran the service without me. And I've thought a lot about this. I did a deep dive into myself. And when I was done, I wasn't ready. I really wasn't. I know Chris saw things a little differently, and there were issues right away. I'm a lot more, a lot more concerned about not doing it just because it can be done. And as I was getting near to my end, I know that I didn't feel like I was completely safe, and I really wasn't ready, and I was starting a new job. And I realized that one of the reasons is learning requires not only immersion, but you have to actually be needed. And when I went up there, you had 2 other fellows all the time that were there when I wasn't there. So when I came up, I was like with another fellow, or we'd have to split the cases. And I was being relatively deferential very often because I'm here part-time. You guys are here full-time. They deserve to do the cases like I did. And I saw them as junior to me. It was like Alex Kalesi, who's now a superstar in San Diego, and Eric Hauk and Robbie Talk, and these guys. And I felt I had to be, like not a mentor to them, but I didn't want to take away from their education. And, it was an unselfish thing to do. But by the same token, I wasn't in the room alone. I wasn't independent enough. You have to go through that. You have to go through that learning curve of insecurity on your own and making those adjustments. And it taught me a lot about how to, the importance of being alone, the importance of taking your individual risk. And like now when I train residents, honestly, once I get a resident to a certain point, I leave the room. Because I know their skills, I know what they can get away with. And Jason, I watch Jason and I do a lot of cases together. And, when he asked me to help him, which is, basically he doesn't necessarily need me all the time, but we do any open vascular case, we're more or less there together. But I know he can operate. But if I'm there at this point, looking over his shoulder and showing him stuff, I let him call me rather than me just go there and lord over it. I know he needs to be alone. He needs to push that envelope, but he's smart enough to know, because he's a humble guy, when to stop. And what's great about him is if he'll reach a point in the case, it's a little tricky, he'll learn from watching me. He doesn't need to feel like he has to show off or do something. And then he goes, no, I'll go, you want to do this? He goes, no, you go ahead. That's why he's going to be great. And, I learned this from watching you and from being at Buffalo, and also seeing what my own, what some of my failures were as a student again. And I also got to tell you, going back, it's a hell of a lot different being 11 years in and being a fellow, because you're so aware of what the risks are. From the groin puncture. I mean, how many times, how many times you heard people just with a groin puncture because the fellow says, it's just the groin puncture, I'll just put the catheter in. Because we're just, at that point, you're just aware of every step matters, and it can be paralyzing. And so all that kind of wrapped up into a thing that but it's definitely affected. The whole thing has been so impactful in my life, to an extraordinary degree. And, in some ways that's what led to the situation that we're in. Little pathways, little decisions lead to big things. And, I'm forever grateful for that experience. And it also learned so much from, Nick wasn't around a lot, but he still remains to this day. People ask me who, which chairman or which mentor, meant the most to me. And even though I didn't operate with much with Nick, it was the times outside of the OR that meant so much to me. And I'm not going to be lying to you. I was so jealous that you had that experience your whole career, and jealous in a good way. In fact, when I first got to Lennox, I struggled with the kind of leadership stuff. Like, how do I build a department? And I had a bad contract, and I was giving up case all the time. And but I wanted to think, I was really struggling internally. And I flew up to Buffalo to talk to Nick about it. I stayed overnight in his house, and we had dinner. And that was a seminal moment. It was a huge, huge thing for me to be able to call on him, and to have that in your life must have been just, I can't imagine having somebody like that, because I never had that. So how is that? What did you learn from Nick? What are the things you learned from Nick the most?
No, I think Nick's greatest gift to me was him saying he's going to get out of my way and let me fly, but always providing that safety net, because we all fall, right? Icarus, too close to the sun, develop some hubris when things go well, and the higher we fly, the harder we crash. And he'd let me fly high, especially as a young chair, or grooming me to be that chair. And definitely, you know, the falls when patients do poorly because of a decision. You know, he was always there to sort of make sure that the landing wasn't fatal, and then help pick me back up. I would tell you, the only advice I regretted from Nick was the advice I did not take. And yeah, he, you know, you talked about the relationship I had with my father. My best friend, was the best man at my wedding. Hopefully I have that relationship with my kids, but Nick and I have a very similar relationship, David. Truly, mentorship is a selfless act, and he was selfless for the decade plus that he's mentored me in Buffalo.
Guys, you have any questions? You guys have any questions?
We have a question here on the Zoom chat that says, retrospectively, how would you answer the question, why do you want to be a doctor? And has your answer changed over time? Elad?
I think, I don't know, in my world, I didn't know much. My dad was a doctor, and I always enjoyed sciences, and I thought I was intrigued by neuroscience. So that was sort of the initial. I think halfway through the career, saving lives, as you heard everybody on this panel say, when you're doing a stroke, it's just an amazing feeling. But I think for me now, it's, you know, can I train the next generation to philosophically make the world a better place through medicine? To me, that I think is going to be really my reason for getting up in the morning. It's not the one-offs of the guys I treat every day. It's the people like David Langer and Chris Ogilvie and the 50 or 60 fellows that come out of here and hopefully train other people and impact other doctors. And through that collective impact, make the community of neurosurgery held to a higher standard.
Yafell, can you also answer that question about how has it changed for you over time?
I think medicine, I mean, as much as, you know, there's complaint that medicine has changed in a bad way over the years, that, you know, things become very constrained by so many political things in medicine. I think it's just a great career. I think I wouldn't think of any other career where we could impact someone's life on a daily basis based on what we do. And, you know, mechanical thrombectomy is one of the best examples. I mean, someone may be dying right now, this single minute, and within minutes of you taking that clot out, that patient is going back to life. I just couldn't envision anything else that, you know, that would have that impact every day on someone's life. So I think it's just, you know, every day I do this. I don't do it because it's my job. Well, it's my job, but it's also my hobby. I could do this as a hobby. It's just a wonderful thing to do. And, you know, for all the students, you know, and that's what I said to the brain turns the other day, you kind of think of this as work. You have to do something in life that motivates you every day to come to work and to have fun in it. And I think, you know, medicine, I wouldn't think of anything else.
There are other questions here that says, Dr. Levy, have you worked with physician assistants? What is their role in the future of neurosurgery? And what would you like to see neurosurgery PAs do to best contribute to the field?
Well, for sure, I think physician extenders, PAs, or NPs, vital importance in our field. I think, you know, I use our PAs and NPs. They complement a lot of what I do. Not only do they work with us in the OR, but I think they're able sometimes to connect with patients and families in a way that's different than the surgeon connects. Everyone has a different style. I know, David, we've talked about this before. you connect a lot better than I do. I think I'm more effective when I sort of have a firewall between me and the patients, because I don't want to have the emotional connection. But so I tend to use my PAs and physician extenders as that sort of emotional bridge, and a more personal contact that I don't typically establish with families, because I feel like then I can do my most objective work that way.
I think that's one of the I couldn't be like that, but I respect the ability to do it. And I think that as I've gotten older, it's becoming harder for me to, it's odd, I'm having a harder time doing hard things as I've gotten older. Because you need to have a certain distance, especially at the beginning, but part of that's the whole, the learning curve is, unconscious incompetence, conscious incompetence, conscious competence, and unconscious competence, in that order. And the trouble is you're very conscious of as you get older, of what you can do to someone, even in the best of hands. And so I do think that getting some distance on that emotionally is probably a good thing. But you have to know yourself. It's part and parcel to who I am. And we can't apologize for it, but that's why people wonder why the hell you became a vascular neurosurgeon. That's just insane, because there's just so many reasons not to do it when you feel like that. But I think part of it was just the technical, challenge of it, the beauty of it, just the absolute joy you get from doing your work, which overcame, I think, a lot of those. And then you had to be the best you could be at it. If you are emotionally sensitive, and if you have to have, then you gotta be on the other side of that. You've got to push yourself to be absolutely the best. And not that everybody doesn't, but you can't not be that person, because I just think you'll fail horribly. You'll fail. And so that may be, one of the reasons why I did the fellowship. It has something to do with it. One thing I do have to ask a lot is, do you still believe that we didn't land on the moon? Do you still really believe that?
That's a private conversation that you and I had. I don't know who's watching this video. I don't want to get anyone upset at NASA, so I won't answer that one.
What do you feel about the round Earth?
The thing I would ask you a lot is, where do you, since you are a soothsayer of the future, what is happening? What's going to happen the next 10 years endovascular? There's a question about, where you think endovascular is going to evolve to. How are you preparing yourself, your department, and your residents and fellows for their careers? What do you? And I know you also, maybe you can talk about why you got an MBA, which probably, in my day, getting an MBA was frowned upon in my medical school class. And I think it's almost like something that people are really considering actively now as part of their medical training. So maybe you can comment on those two things.
Two questions. So I know John Bukvar is not on the phone, but you talk about endovascular for the future. I think you guys are doing some leading science using tumor therapeutics in endovascular. I think people have dabbled in it. There's been some sort of single center studies, but I think the future is going to be, can we deliver agents targetedly, strategically, without poisoning the entire body? Can we deliver chemotherapy to brain malignancies that actually are amazingly effective? And I know that you guys are studying the science behind that now. Stentroids. So what are stentroids? We're starting to see that now. Basically biofeedback. Can we place a stent in the carotid, in the head, that's going to detect when a seizure is happening? And then it's going to basically trigger a pacer to prevent a seizure, so the battery is not running all the time. Or can we place in, these, different electrodes that's going to monitor any type of changes in blood-brain barrier glucose, or that? I think that's the future. These sort of biofeedback implants and the ability to deliver true therapeutics, long-lasting therapeutics. And then on the venous side, right now we're studying treatment for intracranial hypertension, right? We have a few studies. It's much better than shunting if it works, if it's going to work. I'm waiting to see what the data shows. Anecdotally, we've had some great success. We've also had cases that didn't respond. So I think the future of endovascular continues to sort of bridge disciplines of functional with epilepsy and potentially oncology with tumor therapeutics, and then again on the venous side with pseudotumor. As far as the MBA, I think if you,
what do you think of robotics?
absolutely. Right now, right with the Mazer robot, we have robotics and functional. With Rosa, we have
robotics. I mean robotics interventional.
Yep. I think we see that right now in 2 disciplines with Rosa and Mazer, for example, and Globus has a robot. I think we're working on an endovascular robot. Corindus has a robot for cardiac intervention. So there's already cardiac interventional robots. I think in the near future, the next 3 to 5 years, you may see carotid stenting being done with robots. There, you saw Basler, Jefferson has shown a couple of cases of coiling with a robot. I think when robotic technology gets better, it's not ready for prime time yet, but it will get better. And I do think if we can avoid the radiation, or we can do robotic endovascular, as Rafi said, while we're on the beach, then that may be, that is going to be the future. Can we treat patients in communities where there are no endovascular surgeons, but they need their aneurysm coiled? Can you do that from Manhattan and treat somebody across the globe? That would be interesting.
And then your MBA.
MBA. I think MBA, if you want to be a physician leader, if you want to spend time in a boardroom, that's one reason to get it. I don't really want to spend time in a boardroom. I don't feel comfortable with a necktie, as you know, David. But what have we done successfully? We built the Neuroscience Center. We are now building an ambulatory surgical center. We are creating a neurosurgical department that is continually remaining independent from several entities that usually govern neurosurgery departments. Yes, of course, we work well with the university and the hospital systems, but with this MBA, we've been able to position ourselves in a position of strength and independence where we control our own destinies. And I think if I learned anything from the MBA, that's what it taught me. Control your own destiny.
Did you feel like you had to give up anything clinically in order to be a better leader, in order to be a chairman that was effective?
Great question. Yes. And here's where there are chairmen who have a different style. I think about Mike, for example, and Mike and I have talked about this a lot, who's a technical wizard and an excellent friend. To build a department, I couldn't bring in people like Adnan Siddiqui or Jason Davies and say, I'm going to do all the aneurysms, right? You probably wouldn't go there if David Langer said, I'm going to clip all the aneurysms. So to be an effective chairman, you have to say that the department is more important than me. To build a strong department, I have to say, as much as I love clipping aneurysms, I have to share all the vascular equally with all the vascular guys. I'm going to share the call. I'm going to share all the things that I want to do so I can recruit the best and the brightest and build the department. So yeah, I've made decisions that probably, personally weren't in my own best interest, but they were definitely in the interest of building the department. And the day I stopped doing this, and I remind my partners that all the time, the day I make a decision that's in my own interest and supersedes the interest of the department, I need to step aside and let somebody else sit in that seat.
Well said. I think our Insta feed drops in 2 minutes. We usually try to end on time. Just if you have any other, final thoughts for the audience, and for, a tidbit maybe someone told you, a piece of advice that you got from your dad or from Nick or someone in your world that you think about, what you maybe tell your sons. It's a good time to finish on something like that.
Well, David, first I'm going to thank you for having me on. I'm going to give you the shout out. Whenever I think of truly humanity in neurosurgery, David, I think about you. I think, what I learned from you in the year and a half you were up is that, and I borrow this from the bumper sticker on my wife's car, kindness matters. And I think we can often forget that in the stressful environment we live in, but kindness does matter. Humanity supersedes everything. I think you lead by that example. And that's apparent to everybody who watches your special on Netflix too.
Well, I'm sure if they recorded you guys, there would have been a similar ethic, having been up there, except for better or worse, when you're in New York City, things matter more, and on both sides of the equation. And I know you've talked about coming here someday, but given what's gone on now, maybe you made a good decision to hold off, and hopefully we'll see you in a few years when things get better here. So all good.
Thanks for having me.
Anything
you,
else,
Elad.
guys?
Thank you.
Good.
That was great. Thank you.
Thank you, Elad.
Thanks. I'll tell to your family.
I will. Thank you all. Take care.
Everyone.
Bye.